Thank you for the opportunity to speak at the Congress. It's really a pleasure to be here representing Mayo Clinic. So the two topics I'll be talking on are artificial intelligence in surgery, and the second to follow this one will be on robotics in spine surgery. So with that, I have no financial disclosures. The objectives of this talk are to review the use of an artificial intelligence platform for surgical planning, and then at the end we'll explore several cases highlighting the utility for accomplishing surgical goals. If you think about our knowledge in deformity surgery, it's evolved tremendously over the years. In the 1990s, the concept of the cone of economy was developed. And in simple terms, it says that we stand with our torso a certain distance from our pelvis, and if you deviate from that cone, energy expenditure goes up, and so does back pain and decrease in the quality of life measures. But it really wasn't until 2013 when Schwab came out with the specific criteria that allowed surgical targets. What are those? Well, in terms of coronal alignment, you want your coronal alignment to be less than 4 centimeters off midline, and in terms of the sagittal vertical axis, you really want that under 4 centimeters as well. Pelvic tilt is a really important concept, and you want that below 20 degrees. And the pelvic incidence lumbar lordosis mismatch is very important, and we've learned over the years that you really want that within 10 degrees. Well, it's not just about the criteria that we just saw. There's a lot of other studies that say where you place the lumbar lordosis is really important. So this was a paper by Yilgor where it looked at the global alignment and proportion score, and it basically said that in terms of the curvature, you want 80% of your lordosis to be between L4 and S1. So with all the targets that we now have well studied and established, how are we doing in terms of deformity correction? So if you look at a paper using the multi-center ISSG data, it says that only about 23% of patients with a spinal deformity had complete radiographic correction on their follow-up films. In terms of the parameters being corrected, pelvic tilt was the least likely to be corrected. Only about 25% of patients had their pelvic tilt corrected. Well, why does it matter? Because undercorrection or overcorrection in spinal surgery leads to mechanical failure of the implant and pseudoarthrosis. So if you look at hyperlordosis, so if you give someone too much lordosis, they have almost a 23 times greater odds of a mechanical complication in comparison to patients who have normal alignment. And the reverse is true. If someone is underlordosed, 31 times greater odds of a mechanical complication defined as rod fracture, proximal junctional kyphosis, or proximal junctional failure. Well, it's not just a big multi-level deformity problem. The same is true for 1 or 2 level lumbar fusions. If you look at spinal pelvic alignment after 1 or 2 level lumbar fusion, only about 21% of them, or 21% of them that were malaligned were not corrected, and 6% of patients had worsened alignment. So it really isn't just a big multi-level fusion problem. It's the same for 1 or 2 level lumbar fusions. So what is it that makes it so difficult, and why do we keep missing the mark when we have these surgical targets in mind? Well, is it inadequate understanding? I think over the years that's grown tremendously. Is it suboptimal planning, or is it poor execution? It may be a sum of all of these together, but I think artificial intelligence has the potential to change the game here and to really help us meet our surgical goals. So with one such platform, you can basically submit cases and you can have the films analyzed radiographically, and this is done automatically. You can plan your surgery and you can simulate what it looks like all before you get into the operating room. You can communicate with the engineers back and forth, and you can get a response and be able to collaborate on how to best achieve the surgical goal for correction for that patient. So the first advantage of this platform, all the radiographic parameters are automated. So you submit the images, and all the spinal pelvic parameters relevant to the correction will get calculated automatically, and that really gets rid of any inter-user variability. Once the images are submitted, you can simulate the cases as we've discussed. You can pre-print or fabricate rods that are specific to patient alignment. So in this situation, it serves as a gauge for intraoperative correction. How much is enough? Well, if you place that rod in place, it gives you a good sense of have you achieved the surgical targets, And these rods are obviously pre-manufactured and they show up before surgery, so you have to plan and anticipate the correction that you expect to get in order to get the results. Well, the reason these platforms are extremely useful is it takes the data and the surgery that you've done and it studies each of the individual surgeons. And in so doing, the next time you have an operation, it learns how much correction did you actually get and how much can you anticipate getting. And it also looks at the different segments of the spine and predicts what reciprocal changes are anticipated as a result. So here's a case, for example, 63-year-old male came in with severe low back pain. He'd had surgery previously with a 3-level fusion from L3 down to S1. You can see in the picture that he's very flat. He has a flat back deformity. He's compensating through flexion of his knees. He also has a lordosis in the thoracic spine as opposed to kyphosis. And that's just an extent of how much compensation is going on. If you look at his spinal pelvic parameters, 11 centimeters in terms of his sagittal vertical axis. His mismatch is 50 degrees, pelvic tilt 30, T1 pelvic angle 35. So this is someone where it's not going to simply be an extension of the fusion for correction, but you actually have to start from scratch, remove the implants in place, and really get him the lordosis that's appropriate. So here's a CT myelogram. It shows degenerative changes in the thoracic spine. And in the lumbar spine, you can appreciate the extensive fusion mass that you can see. Basically, you can appreciate the extension fusion mass at the level of the facets here and also here. And this patient also has spinal stenosis at L1-2 and L2-3. So we input his information into the software. It basically tells me that the only way to get correction that's appropriate for his alignment is to really do a pedicle subtraction osteotomy, which we plan for at L4. And you can see what he looks like before and what the anticipated correction should look like. And this rod gets manufactured specific to this patient. And here is the plan next to the intraoperative film showing good apposition and that we've really accomplished our surgical targets. These are his before and after films, and you can appreciate the before and after, where before he was really flat. We were able to correct the lordosis in the spine. And look at the thoracic spine, right? Before he had thoracic lordosis, and now he has thoracic kyphosis. What do the measures look like? Well, the computer will basically say, this is the pre-op, here's your plan, this is what you accomplished post-op. So we were able, in terms of our targets, able to get him down from 11 centimeters in terms of his sagittal vertical axis down to -1 centimeter, so more than we anticipated. And if you look at the plan, the target was 1.6. But more importantly, the mismatch was 48 degrees in terms of the PILL, and we targeted 8 and we actually got 10, right? The kyphosis in terms of thoracic spine, 7 degrees to start. We targeted 33. We actually got 30 on the postoperative plan. Here you can see pre-op, the plan, and the final postoperative film showing good overlay of what we anticipated. And this is simply what it looks like in terms of where the spine was in pink, where we wanted it to be in white, and where it actually ended up in green. Here's a second case, 46-year-old female with juvenile scoliosis, came in with low back pain and progressive deformity. She had some lower extremity weakness. This is what she looks like. So significant lumbar curve measuring 53 degrees or 28-degree lumbosacral fractional curve. A lot of thoracolumbar kyphosis. So look at her T10 to L2 kyphosis, 50 degrees. So that obviously explains why she's pitched forward. So if you look at the standing versus the supine film, there is some relaxation, so there is some flexibility to it. And the MRI really shows the rotational component to this deformity that it's going to be very difficult to correct just with screws. So we plan this surgery and we look at whether or not we need to do a pedicle subtraction osteotomy, or with the flexibility of the spine, can we really accomplish our goals simply with inner bodies. And so the computer algorithm proposes, and I approve, basically doing inner bodies from L2 down to S1 through the oblique lateral approach. Here you can see the plan and the final result of that. Again, good apposition, because these rods obviously come specific to the patient. And you can see the before and after, where you're able to correct that scoliosis significantly, and you're able to address the thoracolumbar kyphosis to get that patient correct and optimal alignment. What do the numbers suggest? Well, again, we targeted in terms of the thoracolumbar kyphosis 26 degrees, and we went from 50 down to 18, so we got more than we anticipated. And again, the preoperative, the plan, and the final result showing good apposition across the films, and just a simulation of where the spine was in pink, where we wanted it to end up in white, and where it ends up in green. A third case, and I'll go through this one quickly, 28-year-old female with adult, well, she started on the spectrum of AIS and then ended up on the spectrum of adult idiopathic scoliosis. She came in with a progressive curve. You can appreciate a 55-degree thoracic curve with the apex somewhere in the vicinity of T9. Her kyphosis she's pretty hypolordotic, so very under kyphos. She's only 15 degrees, as a lot of these scoliosis patients are. And you can appreciate there's no significant stenosis throughout the MRI, but there's degeneration of the disc space at the L2-3 level. Here's your preoperative film, your plan. We get the rod pre-manufactured, and this is what it looks like intra-op. Postoperatively, good alignment in the coronal plane, but also in the sagittal plane. And if we look at the sequence of events, but before and after, we're really able to correct that deformity, but also get her good thoracic kyphosis to optimize her alignment. According to the plan, or T4, T12, thoracic kyphosis from T4 to 12, 15 to start with. We anticipated getting her to 30, and we actually got more than we bargained for, which 41, which in this case was good for her. Again, the apposition of the preoperative film, the plan, and good apposition to the postoperative film. So what are the advantages of personalized rods? I mean, historically, we bent these rods manually, and the challenge here is it's very difficult to gauge how much someone actually needs. And when you have a deformity in two planes, while you're bending it in the sagittal plane, it's difficult to control the coronal plane. So the personalized rods have a lot of advantages listed here. It's a gauge of intraoperative correction. The rods are notch-free, so they have a higher fatigue strength. So when you bend a rod manually, at every level where you bend it, it creates micro notches which are prone to fracturing. The way these rods get manufactured, they're manufactured in that specific shape, so they don't have the risk of fracture the way bent rods typically do. It obviously eliminates left-right rod asymmetry. It decreases operative time because you're not spending time at the end of the case bending it. It increases deformity correction, and there's a lot of data that says that it improves patient outcomes. So if you look at the ISSG rod fracture data, the overall rod fracture rate, if you do a deformity surgery, is about 9%. If you look at cases where a 3-column osteotomy was done, that rod fracture rate goes up to 22%. And if you look at the fracture rate in non-PSO cases or non-3-column osteotomy cases, it's about 4.7%. Well, when you isolate the cases where a personalized rod is used, seen in the dark blue here, pre-printing those rods and getting them in the alignment significantly decreases the rod fracture rates from about 9% down to 2.2% for all deformity cases. And if you look at cases with a 3-column osteotomy, it decreases the rod fracture rate from 22% down to 4.7%. There's a lot of other studies out there looking at the utility of these pre-printed rods, which come specific to the patient, and it shows that there's higher deformity correction rates. It's approaching mid-70s, but a lot better than the 25% we talked about at the beginning of the case. And if you look at outcomes at 2%, the correction is sustained, showing improved patient outcomes. So overall, if you look at personalized rods, patients have almost a 3 times increased likelihood of improved correction in comparison to just bending it on the day of surgery. And there's a randomized controlled trial that's ongoing, the profile trial, which basically compares patient-specific rods to those bent in situ to see if there is a comparative difference in how this improves patient care. So as far as artificial intelligence and the utility of predictive analytics, it's given rise to an era in personalized surgery where we can basically anticipate corrections for patients. We can pre-plan their surgeries. We can have patient-specific implants. That essentially improves healthcare outcomes, and it reduces healthcare costs if you don't have to take the patient back for a revision surgery when there's a rod fracture or for undercorrection. It allows for a streamlined workflow with intentional surgical planning, and it really affords an objective comparison between what your intent is from an operative standpoint and what the reality is. And I think the ability to see your objective data allows you to grow as a surgeon.